I'm just going to do a couple things here. So when you want to go to that, launch meeting Zoom search bar, where is it? You should have the screen.
Oh, it's awesome.
Well, listening to some of those just flight tracker,
Not that I can see it clear.
See what there is.
From Schenectady
Later take off.
in Albany. Hey Tim, how do we make this big? All right, guys, we'll start in a couple of minutes.
You're right.
All right, guys, why don't we get started? It's 2:00. Just trying to see who's up here. I'm at Remac with Mike, Tim, Beth, and a few other people. Can we have a motion to accept the minutes from previous meeting?
I can make that motion, John Barons.
Thanks, John. Anybody want to second it? Looks like Alex Downey, I think, made that motion. You guys are this small little postage stamp on my screen here, so it's tough to
That was
see.
John. I can say.
There you go. Okay. All right, so let's go ahead and get started. Well, as far as old business, it really is. The blood committee has been meeting on a regular basis. Beth, when is the next meeting? I think it's April 23rd or something.
And we will be meeting at the airport.
We're meeting at South Albany Airport? Okay, what time? Noon. All right. So we're gonna be meeting April 23rd at the South Albany Airport so we can have a discussion with LifeNet about what they've been doing with their blood. They do have a nice building there that we can meet in afterwards. I have the code to get in if we need to go in there. So, and we can watch some planes take off. But it's coming along slowly but surely. Mike, you have anything to say about it?
I think the most important thing with it is just how incredibly receptive, all of the people on this group are, to having a collaborative intervention. Really working with a group of best practices will ultimately be the way to be able to effectively put forth a program for ourselves, I think, and more importantly for our patients. This can't be a question of reinventing the wheel everywhere it's done. It needs to be done as effectively as possible, and that can then be reproduced in multiple different locations. So that's the idea behind the field trip as well, to see how LifeNet's doing, since they're doing it on such a broad basis now.
Every day, absolutely.
Thanks.
Okay. All right. Anybody have any questions on that at all? Okay, not hearing anything, I guess we'll move on. Just briefly touching on CMAC. We had a meeting back in February. Guess it was February. The dates go by pretty quickly. Really not a whole lot other than TXA is going up to 2 grams. IV, we're talking about EMS wait times, which seem to be not changing a whole lot. Maybe getting a little bit better now that flu and COVID are decreasing. The next CMAC meeting will be up at the Gideon Putnam on May 6th and 7th. It should be a nice venue. If anybody wants to go up for it, that would be great. We'd love to see you. One thing that's going to be on that agenda, which may be a little controversial, is basically credentialing EMS medical directors, which, as we all know, the state is very different. And you live in Long Island or New York City, it's very different than living up in Plattsburgh. So I don't think one shoe is going to basically fit all. We're not going to be able to basically come up with this is the way you need to do it. But we'll see what happens. And anybody's input into that would be greatly appreciated. Regional training courses. Remo has a summer EMT starting on 5/19. Mohawk has an EMT starting on 5/19 as well. Mohawk EMT originals start 8/4 and refresher starts on 8/1/25. John, anything from Cobblesville?
Nothing over the summertime, but we are filling up our paramedic class for the fall, and EMT class as well will start in the fall.
Okay, great, thank you. And I can't tell whether Bob is on here or not from Hudson Valley.
I'm here, Don.
Okay, I just don't see your picture. Oh, there you are.
Okay. So we do have a EMT class over the summer starting 6:30, running to 8:15, and then day and evening paramedic classes starting 9/2 in the fall semester, and day and evening EMT classes as well in the fall semester.
Okay, thank you, Bob. Anybody have any questions either for John or Bob? Well, we definitely have a quiet group here today. All right, well, we're coming near the end of the meeting.
I've actually got one more thing, if I may, Don.
Sure, go ahead.
So the EMS Fellowship hosted a really successful journal club talking about some cardiac arrest articles. The staff from Cobleskill was represented by John, from Hudson Valley represented by Bob. We had a bunch of different agencies that were in the room. It was really a great discussion. Look forward to our next one. We'll put out information across this mailing list again. That one will be coming up in June.
Okay. Where's it going to be? Is it going to San Bellman?
We did the last one at ETech over at the SUNY campus. They were really gracious at hosting that. The venue is really nice. The electronic backup is fantastic. We tried to discourage people from doing this remotely, but for the folks that did, they said that the connection was really excellent. It's got cameras that follow you and that sort of stuff in the room, which is really nice.
Okay.
Similar to what Tim is going to have here shortly, right? Being installed in April 12th. 2 weeks. Less than 2 weeks. So that's going to be pretty exciting. But it was great.
Good.
So I look forward to the next one.
Yeah, it definitely publicize it. I did hear it was working. Okay, anybody else have any items from the floor you want to discuss? Okay. Anybody have anything in here that they want to add?
Actually, I forgot to mention this. I sat in on the Ellis STEMI task force. It's kind of reviewing their cases. And one thing they were kind of stressing is that I was hoping that they were going to send me the data. They were going to try, but I haven't gotten it. But that they had like 20 cases of EMS calls that were either labeled as STEMIs or as chest pains, and they were not in Pulsera. They did not attach an EKG. Now they're getting closer and closer to moving towards Pulsera completely, and they were kind of stressing that really, if we are documenting that it's a chest pain or that it's a STEMI, we should attach to Pulsera the EKG. Just kind of putting that out there.
Okay, thanks, Sean. Anybody have any questions on that from to Sean?
No, but Don, I would just add to that STEMI is a STEMI. And talking to the people at Ellis, the gate is going to open up. It's not going to stop at the ED and then be activated. These EKGs are going to go directly to the interventional cardiologist. So again, even though you may think it's an acute coronary syndrome, STEMI should be just left for STEMI. And unfortunately, the kind of ACS, angina, chest pain should be under the general. But again, at Albany Med, I see the same thing where, again, we're asking for EKGs to be attached to the Pulsera channel.
It was kind of like a discussion that we should probably put out maybe an advisory again, because as we move closer to ending the LifeNet and going just strictly to Pulsera, people should probably get comfortable with that. And there is a little bit of a learning curve with that, so probably stressing it from the region would be a good thing. And then even for now, if we're transmitting both ways, that's better than assuming that it went one way and it didn't go, just to kind of help with that.
Okay, thanks, Sean. Beth, do you think an advisory can go out about that? Okay.
Is Sam Spagnola on by any chance from St. Pete's?
Yeah.
Just wanted to check in and see what the timeline was in terms of the implementation of Pulsera United through the St. Pete's system.
So the new go live date is the 15th, April 15th. I know Beth and Tim and JC at Remo helped me to get out the notice that I sent out. So it's posted on the Remo page as well as whatever mailing list Tim used. And I also have it so that way providers can see it. It's in the availability comment section in our hospitals on availability on Pulsera. And I know Ellis is already live with United. And I think Sean, you're probably talking with Laura, if Laura was on the task force, the amount of false activations they get for the STEMI stuff, as well as like even when cases are getting sent in as STEMIs, and they do attach a 12 lead, the amount of 12 leads that just are not STEMIs has kind of skyrocketed over there.
Yeah, it was like 20 cases that were supposed STEMIs, and of those, 3 had EKGs attached. And of those, I think they only had like 9 for the month.
Yeah, so I know as far as my facilities, we're not going to be getting, we're not pushing anything up to the cath lab just yet. We have to build the teams and all that stuff. So when I say go live is April 15th, that's when that's like our migration date. It's not an absolute, we're going to start pushing stuff to the cath lab that day. It's just that that's when we're migrating, and we could start the team building so that way the cath lab can be brought in on those teams, and then we could start the education and stuff for them upstairs.
Sam, that sounds really exciting. I think the one thing that I would recommend everybody first, back to the folks at Ellis, right? This is a bi-directional communication. So if there isn't an EKG attached, that response of please attach an EKG should be somewhere in that communications channel. The other thing I think that follows with that is let's use this opportunity with St. Pete's coming on board with United to continue to push out messaging of include the EKG on that Pulsera channel and continue to use existing systems of communication. That will benefit all of the system, all the hospital systems that are out there right now. So we have just better information in more places. It's just a question of pushing another button, so it shouldn't be too much of a challenge.
And one of the things that I've been talking about with, like, when we do our Pulsera meetings here with the folks from Pulsera, is that to emphasize, we have a few major cardiology groups in the area. So Albany Associates, Capital Cardiology, Albany Med Cardiology. There are providers crossing, that work out of multiple facilities that are going to be using this at multiple facilities. So the level of familiarity is going to grow over time, just as all the providers and all that stuff start to see it and use it. And the cath lab is usually the first place to kind of get it and get on board with it. Labor and delivery is already on board with it here too. But yeah.
Awesome, thank you.
Thanks.
Dr. Daly, it's definitely a no-go for Albany Med this year for Pulsera United.
I'll turn that question to Art, please.
We're not going to do anything until the end of the second quarter.
Gotcha. Thank you.
I work pretty closely with Laura at Ellis. I'll reach out to her and see if there's anything I can do to help her with that, because I think she's kind of the one that's been the front person for that. And they don't have a EMS coordinator over there, so I'll reach out to her and see what I can do to help her with that too.
All right,
Yeah,
thanks, Sam.
Probably the biggest discussion we had, Sam, was that at this point,
Doing the video.
a provider education thing. They are doing, like Dr. Daly said, when they don't get one, they're sending a message back and saying, hey, can we get an EKG? And sometimes that happens, sometimes it doesn't. So it does seem like just probably a little bit of just an education, getting people used to it again as the LifeNet system sunsets for them.
Yeah, and I'll talk to her and see what their workflow is like, just that way that make sure the providers know, like the interventionalists and the whole cath team know that they can intervene and message and, call and whatnot through the app, and make sure their education on the app itself is where it needs to be.
It did seem like they've got a better handle on it, honestly.
Okay.
They've been doing, but definitely worth reaching out. They seemed like they had a decent amount of knowledge.
Yeah, I'll text her right now to set up some time to talk.
Cool.
Okay, anybody have anything else? Okay, well, and I'm not sure exactly when we're starting the next meeting. Are we gonna move it up to, so we're gonna go one
I
next to next?
I would move the next meeting up to as soon as we can get
Heidi on board.
Rob on board and Heidi on board, and let's see if we can go.
Yeah, okay,
Don't hang up.
say goodbye for now.
There's no second webinar, so don't hang up. We're gonna see if we can get them right on board.
Okay.
Do you want to end this meeting?
No, because,
Well, and
You have to
the
end
meeting,
One,
oh, somebody adjourn, yes.
yes, we'll adjourn it, but not electronically adjourn. So can we have a motion to end the meeting by
I can
somebody?
make that motion to adjourn.
Thanks. Do we have a second? Oh,
And I'll make the second.
okay, sounds good. Thanks, Bob. All right, anybody against? All right, guys, we'll see you momentarily. Don't hang up electronically.
I am here. Rob said he has a meeting at 14:30 at Glens Falls Hospital. So I don't know if he's joining remotely or not in the next 14 minutes. But
Well, but I
happy to start.
understand you were gonna run it, Heidi, is that correct?
Oh, I'm going to be running all right.
All
That's
right,
for
well,
sure.
if you want to start it,
Yeah,
our meeting is done.
I'm fine with that too. So then I will need an approval for the minutes from our prior meeting, please.
I got a second, Mike's got something to say.
Hey Heidi, you're gonna need to make sure that you've got a quorum of the Remac in order to get started, since most of the Remac members will probably not be coming on until 2:30.
Oh, I'm sorry. I was relying on Tim to let me know on a text. Sorry.
3, 4, 5, 6, 7 dots.
Don't we need to wait until 2:30? That was saying.
What's core for Remac? Keep having dots that participate. Oh. Oh, okay. Yeah. But it is a form of horizontal models. Right. Yes, she's good to go. Yeah. She's good to go.
All right, Heidi, you're good to go, apparently.
Awesome. For me, it just sounds like everybody is underwater. So on that happy note, again, did we have a motion to approve? I'm sorry, I didn't hear earlier.
I'll make a motion to approve.
And anyone for seconding?
I'll second that, Heidi.
Thank you so much. I don't have anything up on the agenda for any old
We're gonna keep
business
this
unless
here.
anybody else is aware. No, otherwise, then I'll go up to back to you, Don, for the new business and the blood committee follow-up.
She's on the advisory committee, not the green package.
Oh,
Yeah, you're not in the meeting.
I want to say that looks very familiar to me.
Yeah.
Let me see where I put, oh, that's because it was behind here. Okay, so I have the correspondence though in the DOH disciplinary action reports. Ryan Morgan from Pleasantville, who has suspended for 1 year effective 2/21 and assessed for a civil penalty for $1,000 with violation of Part 800. Ronald Jocko of Hyde Park also had his certification suspended effective 2/27 until such time he completes a paramedic refresher and recertification test, and assessed a civil penalty of $2,000 for Part 800 3AI and 800 Part 3AM and 800 Part 1.15A. Fiorenza Piccarelli for New York surrendered certification effective 3/25 for violations also of Part 800.3AP. Michael Gonzalez of Ozone Park surrendered his certification for 3/25 for violations of Part 800.3, and Ahan Abdullah of Binghamton surrendered his certification effective 3/28 for violations of Part 800.3, and Mark Jeffries II of Jamaica had his certification suspended for 1 year, stayed pending no further violations, and was assessed a civil penalty of $500 for violations of Part 800. Additionally, notification of agency closing was the town of Harpersfield EMS Agency Code 6295, Headwaters EMS Agency Code 1302, has assumed operations for the coverage area. Notification of medication shortage, amiodarone from Greenport RS and Northampton Ambulance. Both agencies are having difficulty replacing their medication. Now, Don, up to you for our academic report.
Okay, well, I believe most of you are on, so essentially,
You did a good job.
yeah, we'll briefly go over it again. The blood committee is meeting again April 23rd. That'll be at South Albany Airport. And we're going to take a look and see how LifeNet is handling their blood. Let's see, there are a number of courses. I'm not going to go through those again. You guys were here. Mike mentioned about EMS Journal Club. Next one is in June. The previous one was well attended, and they did have some good studies that they basically discussed. There was a discussion on Pulsera, obviously, as you guys probably know, and attaching EKGs to Pulsera. If you guys have issues with that, you can talk to Sam at St. Peter's, or also Beth over here, or Mike. Might be able to help you with that. Let's see. CMAC would be the next thing to come up with. The CMAC meeting, and that's the last one we had. TXA was changed to 2 grams. The state medical director position hopefully is going to show up within the next 6 months, but we've been hearing that for a while. Hopefully that will occur. EMS wait times don't seem to be changing that much, although there have been some improvements from what I understand. COVID and influenza are dropping off. Next CMAC meeting will be at the Gideon Putnam, the 6th and 7th of May in Saratoga. Should be a nice venue. And there'll be some controversy as to how to credential medical directors. As we previously talked about, upstate is very different than downstate, so it's interesting to see how that goes. Other than that, I have nothing else to add from academic, unless anybody has any questions. Okay, Heidi, back to you.
Fabulous job. Your turn, Dr. Daly, for the QI report, please.
Back on.
Thanks. So, in terms of process improvement, we actually had a really nice, appropriately tight, meeting without a whole lot of extra noise. Went through and spent some time talking about what our agendas were going to be in each one of our meetings. Our next meeting will be June 4th. We'll be talking about STEMI, which will tie in really nicely to the concerns that both Sean and Sam were talking about. And we'll see how that works out in terms of notification. We'll add that piece in as well. I think that'll be important. Art, if you can get us data from the Albany Med Health system on that, that would be really good as well. Making sure that notifications are coming in appropriately. We talked about CARES and how 2024 data was completed thanks to a lot of extra work by Beth, which is fantastic, and Susie Burnett chasing down individual cardiac arrests that some of the demographics were incorrectly entered. That worked out well. And then we talked about addition of agencies to the CARES program. Agencies that are engaged right now and medical directors that are on the line, having your agencies actively engaged in CARES, looking at the Utstein criteria that they are focusing on is really a good way to continue to improve outcomes for the patients in your jurisdictions. So I actively encourage everybody from being as involved as possible. Spend some time talking about the ARAMS, Remsko's Life and Sirens recommendation, which Tom Smith worked on with a group of folks in that region. I think it's an excellent document. We'll be passing along both the NHTSA, National Association of EMTs, National Association of EMS Physicians document that was written by Doug Kopis and an expert working group, as well as Tom Smith's documentation and what has been going on in Volusia to help agencies develop policies of their own. And we can consider whether or not that's a policy that we should think about doing here too. But certainly having it done on a grassroots effort and agency by agency basis may make the most sense. And then we continue talking about 5 different metrics that we're looking at on a regular basis. One is antibiotic use and open fractures. The second is ketamine utilization to assure that we have regional oversight to help with the regulatory concerns, intravenous nitroglycerin, the administration of TXA, and sodium bicarb use in cardiac arrest. So we talked our way through each of those as well. We certainly encourage any medical directors and agencies that are not involved with these medications in their own agency formularies, since each one of these is, with the exception of bicarb, is a optional medication, to consider implementing them for the good of your patients. So, thank you.
Thank you, Dr. Daly. I see, Tim, you don't have a report for us, so our agency updates and upgrades for the BLS, albuterol, epi, glucometer, Narcan, CPAP, and 12-lead iGel. East Glenville Fire District number 3 for BLS 12-lead, and Town of Hancock for the iGel. Yay team. For the BLS First Responder upgrades, the BLS First Responder update from the Village of Hancock Fire Department. Congratulations. And apparently all of our PAD apps were reviewed, and the QI coordinator and proper order: New Cheney Library, Steventown Fire, Bethlehem Children's School, Albany Academy, St. John's Episcopal Church, First Responder Presbyterian Church, Fenimore Farms and Country Village, Fenimore Art Museum, and Equinox have been updated. So congratulations to those public access defibrillators. So for new business, I have the community paramedicine initiatives from Valatia and Cambridge Valley. You guys want to talk about that?
Sorry, just for a quick update. So Steventown Volunteer Fire is somehow written as an original. They've had public access to fibrillation for probably about 20 years. So I'm not quite sure how that ended up being filed as an original.
I think that because they changed the name over for their medical director, that might have been an oopsie.
Thank you.
Hello, everybody, and thank you for having me here. My name is Robert Hawley. I'm with Valatia Rescue Squad, our MIH specialist. Mark, you on?
I'm here. Hi, Mark Spezio, Chief of the Cambridge Valley Rescue Squad and Mobile Integrated Healthcare Team.
I'll let you lead, Mark.
Okay. So thank you for the invite. I think what prompted the invite is both Valatia has been doing this for a couple of years. We've been in the business for almost a decade now, and we're expanding our territory as part of a grant initiative into the northeastern part of Rensselaer County, a little bit further than where we normally cover. And I just reached out to the Dr. Daly regarding it from the Remac perspective, just to let him know that we'll be, going into the county, just so there's no surprises. And so he invited us to do this presentation. So, briefly, kind of where we are today, collaborative models for community paramedicine, for medicine and community paramedicine alike, is an initiative that is being sponsored by or managed by the Home Care Association of New York State and Iroquois Health through a very sizable multi-year grant program from the Mother Cabrini Foundation. This is year 4 of the funding. 2025 is year 4, which is really quite unusual. And in this particular community paramedicine initiative, there are 7 regions within the state that are participating in these pilot programs. They include Broome County, obviously Columbia County, and Jefferson County were the first 3. And since then, I believe it's Herkimer County, Tioga County, and there's one other county in the western part of the state that's with the second round of folks that are participating. And we joined on last year just in an effort to keep our program going until looking for another funding source. So I'll let Robert give a little bit of history over this particular program, talk about some of our results real quick, and then a little bit of what we're doing independently.
So Valatia Rescue started our program as one of the first pilot programs of this HCA and the Mother Cabrini Foundation grant. Our pilot technically started in 2022, and we were brought on board as the only EMS agency that ended up joining our pilot for the Columbia and Greene County initially. And we started seeing our first patient September of 2023. Can you go to the next slide, Tim? So as Mark had said, the pilot programs currently are from 2022 to 2026. It integrates the core health system partners and practitioners from hospitals, home care, primary care, EMS, and other community partners in a coordinated manner for support in the community. Supports home care by serving as a bridge in that critical points in the care transitions. So we're mostly seeing those patients. The goal is the initial 30 days after they're being discharged from that hospital. Most of the programs currently have about a 90-day goal of being in the program. This improves communication, access, and continuity of care being flexible, choreographing with the partnered assistance of core health system partners, and it meets the health needs of the community while simultaneously preventing potential avoidable hospitalizations and reducing that emergency department usage by those super users. Next slide. Go ahead, Mark.
So, with any of these goals, the idea of community paramedicine is to reduce unnecessary 911 calls and unnecessary ED visits. And certainly, with all the things, even what, Dr. Doyle was just talking about with the ED wait times, if we can keep the patients that don't need to be in the ED out of the ED, that's just going to help the system in general, including EMS. We do provide a lot of assessment regarding social determinants of health. While we're on these, particular visits, patient education and chronic disease management education for the patients is a significant part of what we do. Just simple things like zone tools and, weight logs and diet logs, those kinds of things make a world of difference in helping these people be able to support themselves at home. We also look at individualized, patient-centric care across the continuum. So we are involving as many people as we can in the community paramedicine, environment. A lot of referrals are made from the CPs to everything from social service organizations like our county office of the aging, but even to local food pantries and those kinds of stuff to provide services, Alzheimer's Association support for caregiver burden, those kinds of things that people may not have those connections to without the involvement of us being there. And we also look at a holistic picture. So it's not just, the critical nature of like in 911, when we're going there, we're dealing with, we're on the scene with the patient for 15, 20 minutes. We're doing an assessment, we're loading them up and we're heading to the hospital. This actually changes our entire mindset. So when we go, to visit these patients, we're doing safety assessments in the home. We're doing social assessments. We're helping connect folks with appointments. Well, I have a referral for physical therapy, but I have no idea how to even start that process. Who do I call? Why do I call? When do I call? How do I schedule? How do I get transportation? So those are all key components of what we do on top of the actual medicine, if you will. We can bounce to the next slide, please.
So as Mark had said, currently there's 7 pilot programs altogether. The first 3 were Columbia and Greene County, Broome County, then Jefferson County. After that, we brought in Washington and Rensselaer County, St. Lawrence and Schuyler. And then we brought in just last year, Washington, Rensselaer County, and Herkimer and Oneida. So these are all rural counties facing challenges accessing care. That is the primary point of this program, is that rural areas. And these are for patients with multiple chronic conditions. CHF, your COPD are the 2 that we're focusing on the most, but we do have qualifications for those with frequent falls, diabetes, and other comorbidities. And then we also do the daily activities of referring to like food bank and stuff like Mark had mentioned. Next slide.
So I think most of you are very, intuitive and understand the concepts of community paramedicine. And, at the end of the day, it's the same concepts that have been around for, the 10, 15 years that CP has been around. EMS is in the community. We know the community. We generally have resources that are available. We have the initial medical background and knowledge, with some additional training, both in skill set, knowledge base, and certainly social determinants of health and chronic disease management. We can bring that skill to the patient. And the idea here is to fill gaps. We're not recreating the wheel. We're not trying to, provide a service that already exists in these communities. The overwhelming majority of the patients that we're dealing with do fall into gaps. They don't have, either they're not eligible for home health care. Home health care is not available. Home health care is expired, so they need to transition into something different. They're at high risk of returning to the ED. Maybe they don't have a social support. So the idea here is to use these existing resources, these well-trained existing resources in the community, and just change their skill set to deliver EMS in just a different format, in a different way.
There are currently many other states already doing this. And New York is unfortunately just a little late to the game still. If you can go to the next slide. So in the past year, we have proven a decrease of 61% in emergency ER visits and a decrease of 78% of hospitalizations within the data of our programs from the 7 pilot programs. Altogether, we had seen 688 visits to the ER prior to our program. And then about 6 months prior, and then 6 months post was a total of 265 visits. These numbers here are actually right in line with what the rest of the country and the rest of the programs that are already doing MIH are showing. It is a huge reduction in that ER and hospital admissions. And we're even reducing those 911 calls. Next slide.
So just the data that you just saw, that all of the slides have come from a one-page paper that the Home Care Association of New York and Iroquois Health put together along with iPro. Part of this grant is they have contracted with iPro to do all of the collection of data. So they actually put this one pager out a couple of weeks ago. I'll email it to Tim, and that way you can distribute it so you have that information. So Robert's group has been covering obviously the Columbia County area near where they've been. They also have been doing some work in especially in eastern Greene County, and have started to migrate north into southern Rensselaer County. Our program initially started in Washington County and in the town of Hoosick in Rensselaer County, just following our regular ambulance operating territory. The nice thing about community paramedicine is we're not the ones transporting patients. If patients need to go, we're calling the home ambulances anyway. So we really don't need to be limited to our approved operating territory for these programs. So because of need that's been identified by the two VNA services in Rensselaer County, Albany VNA and the Eddy, there's a need for both of us to expand and provide more coverage into Rensselaer County, and that's kind of what sparked this discussion. So if you look at the map, the kind of the pink area is the area we really are not going to cover. Those are suburban and the urban areas of Rensselaer County. North Greenbush, East Greenbush, Troy, Rensselaer, parts of maybe the northern part of the town of Schodack in that area. Vallejo is going to cover the southern part, and it's really, we looked at like a 45-minute ride time from our stations to there. For those of you not familiar with where Cambridge is we're in the far southeastern portion of Washington County. Washington County, from its furthest point on the south to the Ticonderoga line, is about 95 miles. So we have a pretty big county geographically to cover. We're going to cover Hoosick, Grafton, Petersburg, Pittstown, Hoosick, down into Berlin, and maybe a little bit in the northern part of the town of Schaghticoke.
And we're going to be doing the Nassau, Schodack area, Steventown, that type of area. As Mark said, if you can go to the next slide. The areas were not covered because this is for rural health only, is that Brunswick, East Greenbush, North Greenbush, Rensselaer City, and Troy area. And then for Greene County, I currently only do that 45-minute radius from Valatia Rescue. So unfortunately, it is needed up there, but the mountaintop area, Durham, Hunter, Windham, Tannersville, is just not feasible for me at this time. If you can jump next slide. So Valatia Rescue Squad, our primary partners right now for our 3 counties that we cover is Columbia Memorial Hospital, Albany VNA, and the Eddy VNA. We regularly meet, and I get regular referrals from both the CMH inpatients and all the CMH doctors' offices, and referrals from both the Eddy VNA and the Albany VNA. They have really utilized our program, and it allows the Eddy VNA to discharge their patients a little sooner than they would have been, is what they're finding with us being in there. So far, we've done 140 referrals have been sent to us from many, many different sources, from Office of the Aging, many, many different doctors' offices we've done presentations for. So far, 111 referrals have been for Columbia County, 28 for Greene County, and 1 for Rensselaer County already. Rensselaer County has only just been brought on to the program as of January of this year. So Rensselaer County is just starting out. Volusia Rescues currently is 1 full-time MIH specialist, myself. And we are working on expanding the team with additional MIH providers. Myself and any providers we do hire are currently going to be paramedic level only, and we are only doing those online with Remo, or they will be being placed online with Remo. We've completed since our start 590 visits, which is average about 3 to 5 visits per day for me. I've had 52 people in the program, and we've managed to do 28 ER avoidances where they've called me and I've been able to arrange with their doctor's offices steroids called into the pharmacy, do some neb treatments on scene, and keep these people out of the hospital, and manage to get them scheduled an emergent doctor's visit or just treat right in place. Our average length of visits about 50 minutes. With being such a large area, my total travel time is a significant amount, which is 40 minutes. And our average days in the program currently is 110, with our goal being closer to that 90 days. And then most of our patients have been Medicare, but we also have a small amount of Medicaid and a couple of full insurers. Next slide. We also do our HELP program with our MIH program, which is a hospital equipment or health equipment lending program. And that's DME, like hospital beds, rollators, wheelchairs, stuff like that. And we have actually over 200 pieces of DME and have utilized that program 158 times. Next slide. And it's you.
All right, thanks. So as I mentioned before, we've been in this space for a long time. Before we were kind of a under the radar approved community paramedicine program before COVID, as one of the 5 original in the state. And actually our program was the first to see patients in the state going back to December of 2016. So, in that time, we've done well over 1,000 visits and have touched points with about 300 patients. Prior to this new program, we tracked our things through what we call the diversion rate, and that was anytime we were at a community paramedicine encounter where we had to activate or speak directly with the patient's physician for any reason. So, and we documented that as kind of a diversion away from hospital time. During COVID, what was really great is during that pandemic, it was an instantaneous switch. I worked with some other folks at the state level to get approval for the vaccination program and the testing program. I know Dr. Daly was very involved in that as well, along with some of the other folks that are on the call. We created a county vaccination team in about 10 days. And over the course of the vaccination periods, before everything kind of slowed down and transitioned, we did about 70,000 vaccines within our county. And that's not bad for a population of about 62,000 people. So we did a lot. We also became the only COVID testing site, rapid testing site in the county for about an 8-month period, and did a fair number of those. We also branched out during COVID, and one of our other initiatives is we have an embedded EMT in our program in our school system. We have a central school system with a population of about 900 kids, 2 school nurses, no assistants, no dedicated secretarial staff. We started it in COVID, and even to this day, we still have it in there where we have an EMT that goes into the nurse's office and does everything from respond to calls on campus to assist in every way possible. And on average, our EMT in the school touches about 60 to 70 kids per day in some manner in the nurse's office. So that's really kind of a cool thing to keep going as well. And our current program, the one that we're in with Robert and the Volusia gang, Our partners are the Adirondack Health Institute. We worked with them during the district project several years ago as a big funder. They're our grant managers. It's what they do it well, and it's a whole lot less paperwork for me to have to worry about. So that's great. Our hospital partner is Glens Falls Hospital. They're our biggest hospital system or direct hospital within our county as a whole, not necessarily ours, but in the county as a whole. And also from not only the ER, the physical plant perspective, but they have several primary care practices within the county. From a home care perspective, for the Washington County, our initial partner is HCR Home Care. They're a big player here. And both the Eddy and the VNA play in Washington County, and now that they'll be our partners in Rensselaer County, so it'll be opening up more doors into our county as well. As far as the partners and referrals, our largest referral base comes from our primary care providers and offices within the Glens Falls system. That's been historic. We've had those relationships now for 7 or 8 years, so it's kind of a no-brainer. We do receive a lot of referrals from those folks. We have had probably our biggest challenge thus far is getting referrals out of the ED. We've met, we've marketed, we've pushed, we've done all the kinds of things that we can do on our end. They come in dribs and drabs from the ER, but that's the area that we think we can do the most or have the most benefit for patients is getting those folks that 20 years ago they might have gotten a bed upstairs, but we're pushing them out of the ER now, and there's a high likelihood they're coming back. So why not send CP? But we continue to work on that. We also get some referrals on occasion from Hudson Headwaters and from Southwestern Vermont Medical Center. So we work pretty closely with those folks as well. But, hey, if you refer it and you have a doctor or some sort of healthcare need, we'll find a way to get you into the program so we can see if we can help you. So next slide. Almost done, I promise. By the numbers with us in this program, we started seeing the patients in this particular program in November of 24. We've had 68 patients total referred to the program. We still have 47 that are active. Some of them are a little bit longer than the 60 or 90 days. We have the capacity at this point. Average time on task is in that 45 to 60 minute area, and we do 5 to 7 visits per day. We could do more, but it depends on how far we have to travel. We do try to group them within certain geographic areas, just kind of do some smart scheduling there. Through the grant to this point, we have 60 hours of dedicated community paramedicine shifts assigned per week. That will probably go up to 80 once we get moving on the Rensselaer County end of it. And we use EMTs. We use all 3 levels of certification. We stratify it. We keep everything within the scope of practice. So even like wound care as an example, we have EMTs doing wound care. They take a practical skills exam. We put them through all kinds of in classroom things even in their basic certification course on how to manage wounds, whether it's a burn, it's it's a bleeding, it's whatever the case may be. So with that little extra training, that works really well. And our Home Healthcare Association is the one that helps us with that specific training, and we've had fantastic results from that. So what are some of the things that we're doing? The patients we're seeing, chronic disease management, we're really hammering on our COPD and CHF populations. Thankfully, a lot of our referrals coming through are that group, and we're really, I think, making some difference there. Medication reconciliation, we know that geriatric population, the biggest reason they go to the hospital is because they don't take their meds right. So we're really honing in on that. We're doing a ton of lab draws. I think that's really kind of an important niche to fill. We're not just becoming a traveling phlebotomist. These patients are enrolled in the program. The majority of it is we're also doing some like potassium checks for CHF patients. And we're most likely, in fact, not only most likely, we're going to change our LSL to include some of the, the whatever the term is, the things that we can do, the waived procedures. There actually is a device for point-of-care testing called a Piccolo machine that all of the tests in that are waived. So we're upgrading that. We're going to buy that piece of equipment. So instead of drawing labs, driving to, a clinic or a lab that is only open certain times to drop them off within certain parameters, we're going to be able to draw the tube, analyze the tube there on scene, and then provide the information to the physician. And then wound care, as we talked about. Some other things, I just talked about the point of care testing. We're still doing our COVID test. We've got the double swabs now for COVID flu. We get to a patient's house, they're not feeling good. They've got the sniffles. We stick a Q-tip up their nose and, hey, are you sick or not sick? Because these people are at risk. If they're sick, we call their doc, and then the doc can decide whether to do antivirals or whatever the course may be. Our service medical director is very big into community paramedicine. He's actually been heavily involved with community paramedicine from physicians and advanced care practitioners going into the home for the past several years. And he's actually retiring from that soon. So he's becoming more and more involved, which is always a great thing. So we have developed some actual treat in place protocols. So we have a bronchial dilation protocol. We go to our CHF patients and we use the zone maps. If they're in a zone tool, if they're in the yellow area, we're going to bronchial dilate them and see if that corrects the problem. Whether just, oh, you have wheezes, your SAT's low, we're going to call your doctor, because a lot of times if the primary care physician can't see them, their default is call an ambulance and take them to the hospital. Where if we could provide some on-scene treatment, make them better, then call the doc and say, look, this is what we did. We could probably keep them at home. Our in-home diuresis program or protocol is being worked on now, as well as a dehydration protocol and home infusions. We actually got a call and we were going to do that this weekend. Gal that was going to come home on IV antibiotics didn't qualify for home health care for whatever reason, and we were going to assist and manage with just those home IV antibiotics. These things only work if we can do treat in place. We can go take vital signs on 100 people. We can go tell people to pick up their throw rugs and be safer at home and don't fall down. But at the end of the day, those are not going to, they'll keep some people out of the hospital. But we've got to be able to do these other things and these other skills so that we keep these folks out. It's all expanded practice. It's not expanding the scope. It's expanding our responsibilities, but staying within the scope of practice. And that's one of the really important parts. Next, and I think it's the next to last slide, please. So another thing that I'm working on is I was fortunate enough a couple of years ago, and I saw some of the colleagues on Aiden and Dean just on the State Rural Ambulance Task Force, and I know this was something that we worked very hard to include community paramedicine in those recommendations that are out there. I've just recently been appointed to the 3018 stakeholders group, and that's the permissive legislation for community paramedicine. I can't say a lot, obviously, because the group is still working, but we are meeting, which is a good thing because this will allow for hopefully for the legislative body to approve the extension, because all of these programs will expire here this summer according to the current legislation. So we're looking for an extension for another 2 to 3 years, and I think that's going to happen. So this group is meeting bi-weekly. We have some subgroups, and our tasks, they're written there. We have to write the regulation to permit community paramedicine programs for being part of longstanding longstanding legislatively approved programs in the state, and allow for expansion beyond just the 55 programs that are currently approved in the state. So also, I also sit on the STEMSCO Innovations and Research Committee, and community paramedicine is a large part of what that group does as well. And one of the things we're looking at is working with Wadsworth on some of the not waived testing that can be done for point of care testing to allow not only community paramedicine programs, but even certain 911 calls if we're using telehealth or doing those kinds of things to be able to do more point of care testing than what we do, which may again do more treat in place and less transport to the hospital. I think the last slide is, I think probably Robert is in the same boat. Anybody up for a ride along? Call either one of us. We'd love to have you, jump in our EASVs and go out and see a patient or two just to see how it works and what happens. It's different, and it's fun. It's exciting. It's not for everybody. Not every paramedic or EMT wants to do it, and not all of them should do it. But it's certainly a really interesting and very rewarding process, that's for sure. So for my part, thank you all for the opportunity to present. Certainly, you can grab my email and, shoot me an email, a text anytime, and happy to talk further. So thank you from my end.
Thank you both for your wonderful presentation. And before I ask for any further questions for either one of you, I just wanted to thank everybody for their time today. I have to now show up for my trauma shift. So have a wonderful day. And if there are anyone if we need anything to vote on, we just have to check also if we still have a quorum. Thank you so much.
we got Hayashi and so we're still good.
I would turn it over to Mike.
So Dr. Hayashi came in here at Remo, and we do still have a quorum, so we'll continue with the meeting. One thing that I think is really important for everybody that's on right now for us to remember is that the department has reinforced with the program agencies that they would like us to make sure that we are compliant with open meetings law and get people back to in-person meetings. I recognize that that is a significant strain on some of our days. I recognize for everybody on this call that that will, potentially impact your voluntary participation in these groups, providing leadership to the region. I hope we can come up with ways to assure that we indeed have quorums to be able to conduct business, but at the same time can continue to encourage the diversity and involvement of our membership from across the this really wide and varied pair of regions that we now are working with. So that will be a challenge moving forward to make sure that we are in compliance with the rules. From there, there is a current shortage intermittently of amiodarone that I just wanted to mention really quickly. Back in 2019, we had a similar problem and noted in an advisory that indeed amio could be lidocaine could be substituted for amiodarone in the protocols appropriately. The way the language of the protocol currently reads is that lidocaine is a physician option only, which becomes very interesting. Amio obviously is standing order. We're replacing it with a medication that we then say needs physician authorization. Anytime we do a drug substitution, the drug substitution is expected to act the same way in the protocol. We'll put an advisory out to say that if you need to substitute lidocaine for amiodarone, please go ahead and use it on standing orders as you would the amio. But that said, don't forget that if you are going to need to make that substitution, you need to advise the program agency. So please make sure to send Beth an email should that be impacting you. We only know of 2 agencies that it has impacted. One of those agencies has already recovered from that shortcoming. So hopefully that continues to improve. Is Robin on right now from Albany Med? Just to talk about DNV real quick.
Hi, Dr. Dale, can you hear me?
Oh, awesome. Thank you, Robin. Yeah, please. If you just let us know a little bit about DNV and what it means for the stroke program, that would be fantastic.
Yeah, so traditionally, Albany Med has been certified through the Joint Commission for accreditation and for certification, so heart failure and comprehensive stroke. Last year, the organization decided to move to a different direction and go with DNV. I don't know if people have heard of this, but it's another accrediting body. When you look at the standards and regulations for stroke specific, let's just say, very similar to Joint Commission. There's some nuances regarding to, let's say, direct to CT. They look at direct to CTA, time start, stuff like that. There's some nuances, but the regulations directed by CMS and American Heart Association are very similar. The biggest difference, and people that might have been on the calls, their presentation and presence is much more cordial. They're very collaborative. They're very insightful and helpful. It rather than feeling punitive. I mean, we did get called out on a few nonconformities, as they call them, mainly documentation issues regarding to reassessments and vital signs. Nothing really significantly found. It was actually an excellent survey. We haven't gotten our official documentation yet of all of the write-ups. There were just a few that we're going to have to go through and do some plan of corrections for. We do anticipate getting our recertification. There shouldn't be any issue with that. It takes 10 days for them to get us their write-ups, and then we have to get 10 days to give us back our plans of correction. But I will say, the vibe was much different with DNV. It was a really great experience. Also with DNV, they come yearly rather than every 2 years for certification. So every March we'll anticipate them coming, which kind of keeps us in a constant state of readiness. And each subsequent follow-up becomes more of a follow-up rather than a full just drawn out survey. So that's kind of just a quick overview. I don't know if anybody has questions or anything for me.
Now, Robin, I realized it was a last minute ask to have you come on in and speak, and certainly after going through all of this for that visit last week, I didn't want to hit you with a whole lot more, but it really was to me remarkable to have an accrediting body come in and be really that collaborative. And I agree, collaborative, not punitive. They really were working on what I would consider a process improvement accreditation, and that was really refreshing.
It was very refreshing. It was, and they gave us some really great pointers from other organizations that they've been in, and so I know we look forward to working with them moving forward. So yeah, it was great.
Oh, thank you. I really appreciate you coming on and doing that.
Yeah.
In terms of other things in our current agenda, the first is advisory 2401, whether or not we should be rescinding the fluid shortage. The ask right now is to not rescind that advisory at this point, leave that in place. Continue to ask people to minimize fluids when possible. Although I believe we are almost completely through the crisis situation that we were in, which is good, really good. Dr. Hayashi, do you want to talk about finger thoracostomies and LifeNet? Yeah, why don't you come and use this one? Oh, you want this one or that one? Which one? There you go. Thank you. All right, hi guys. I'm Dr. Hayashi. I'm one of the physicians at Albany Med, and then I am the medical director for 3 of the local LifeNet bases. What I wanted to talk a little bit today is that LifeNet would like to start doing finger thoracostomies for failed needle decompressions. So they have a new PCG, and I meant to bring it today, and then I ended up doing an RSI with Mohawk, and it's a whole long story. Anyways, I will email it out to you guys so that you can take a look at it. But what it comes down to is that needle decompression, unfortunately, frequently fails, especially in the field, also in the emergency department, as far as making it into the actual thoracic cavity. The lateral approach is slightly better than the anterior approach, but both of them, unfortunately, don't always make it in. And there's been a number of local cases as well where my flight crews have done multiple needle decompressions for a patient that's decompensating and have either failed to get in or it's taken multiple attempts. So the plan is that if there are 2 failed needle decompressions on a patient with suspected pneumothorax and or traumatic arrest with thoracic trauma, that the third attempt will be via finger thoracostomy. LifeNet does extensive training in the both simulation lab as well as with cadavers to make sure that they're well practiced. There is a fair amount of literature out there in the aeromedical world that suggests that this is a safe practice for at least aeromedical providers that are well trained and well practiced. This is something also that I teach in my EMS cadaver labs, and I think is a relatively safe and effective and important treatment for these really critically injured patients with, I think, benefits that far outweigh the risks. Obviously, the risks are, if you go anatomically too low, you could end up in the abdominal cavity. But I have yet to see a finger thoracoscopy that's ended up there. Maybe I just haven't seen enough of them. But I think that in this patient selection where we're doing multiple decompressions to try and alleviate this tension pneumothorax in a decompensating patient, again, I think that the benefits outweigh the risks. I guess at some point I would requesting you guys haven't seen the PCG, so I'll have to send it out, but I'm requesting approval of patient care guidelines, site protocols for the LifeNet folks.
Does anybody have any questions about it or any other thoughts or concerns? Crickets. Bueller.
I can have a question,
Yeah.
we did this in San Antonio. So the issue that goes on with this is that in the first part is how we implemented it, which is arrest bilateral finger thoracostomies. Person's already dead, not good for
Not gonna make
thoracic
it worse.
trauma. You're not going to make it worse. I would tell you that in the workup and testing of this, I'm not opposed to do it, and I'm also was very much involved when the needles failure rate in the military for how often that fails. So I am a supporter, but I want to highlight that the morbid obese that you try to stick a finger in with large amount of sub-Q fat, you actually might be, if you're doing it for decompression, it has a high rate of failure, even if you get into the thoracic, because you're not keeping the hole open.
It re-occludes.
Yes.
Yeah.
Pretty quickly, pretty fast. So I would say that, it does do the alleviation. Not keeping the hole in there if you have hemothorax is problematic. I'm a complete supporter for, as you mentioned, the thoracic injury that is pulseless, doing it because I do believe it's the most effective way to quickly say, is there blood in there or something that I can make this person return to being alive? But I do caution, because as we train people, cadavers are really thin. And sim models are also not with the axilla of about 6 pounds of fat, which is what you can run into, and then it's problematic. But that's all I got.
Okay, fair enough. Yeah, and I think this is a starting point, whether the indications for this, extend from here will be something to be seen, but this is sort of a starting point. We'll see how it goes. And again, it's primarily, since we're not sticking a tube in there, it's more for the immediate decompression of the tension rather than fixing a simple pneumothorax or hemothorax is also not going to do a whole lot of good for, although we will be able to identify it, and then obviously that'll be important handoff information.
So this is in collaborative protocols or pilot program?
No, this would be specifically for LifeNet and their patient care guidelines. So it's going to be a little bit, I think, till this would be a thing for ground EMS in New York State. Has there been any discussion about using POCUS versus traditional landmarking? We have not. So for one thing, LifeNet at this point in time is not using point of care ultrasound. And so we have not entered in a discussion about identification specifically. These are the patient selection is going to be either in folks who already have a known pneumothorax, say an interfacility transport that decompensates during flight, and so now we have suspected tension from that, or somebody from a primary 911 call where there are enough clinical indicators, absent lung sounds on one side, clear thoracic trauma, hypoxia, tachycardia, hypotension, et cetera, that we have a high enough suspicion for tension pneumothorax that it is worth doing, and probably would be something that would be done in the trauma bay on arrival anyways. Any other questions or thoughts? Okay. I will make sure I get those patient care guidelines out, and hopefully we can get it approved.
I'm actually going to direct this question to Don, who's standing right behind me here. So finger thoracostomy, I think is good medicine. I certainly agree with Kurt that there's significant challenges when you get into large patients. I think that it would be appropriate for this to go to med standards in May for a discussion of it at the very least. We don't approve the patient care guidelines that LifeNet uses. at the statewide level. We review them at the regional level. But I think it would be appropriate for this to be an agenda topic there for Dr. Raybridge and that committee. What do you think?
Sure. I mean, it would go to, would it be something that would be incorporated in the collaborative protocols?
Right.
But it certainly would be reasonable to get statewide EMS physician guidance, I think. Maybe like that, sure. Why
Yeah,
not?
I think that would be good. Dr. Edwards, any thoughts on this at the stack? And just having a discussion there about this being added in?
Yeah, I support it because in San Antonio they implemented it, and then we had people coming in with 2 holes in the side of their chest, and we weren't like apprised. It caught us quite off guard. So I'm not there to say, hey, we should vote on it, or they can give some more thoughts that are on there. But I definitely think that since LifeNet does fly a pretty big area there, to try to let people know that this is something that could be happening, because it can be a little bit startling to say, hey, what happened here? And realize that that's part of the protocol. But yeah, that's kind of my thought on that.
And Dr. Hayashi, in terms of the procedure, are you guys following that finger thoracostomy with antibiotics, or is that something that we need to make sure that we're following through on in the hospital?
That we need to make sure we're following through on the hospital. It is not part of the protocol. In fact, we said that it would be also indicated. I suspect that a lot of the plaintiffs would do that as well, but that's, in these sort of cases, it's not going to be their primary thought, because they're concentrating on decompensating a patient.
So for people who are online that can't hear what Dr. Hayashi is saying right now, what he's saying is that the flight crew is going to be primarily worried about a decompensating patient, taking care of that thoracic trauma and potential tension pneumothorax, administering blood products, and doing what they can to save this person's life. Antibiotics are going to be a part of their future, but are not a part of that initial bundle of care, along with the finger going in to release the tension. Okay. That makes great sense. Makes great sense. Okay. So thank you for letting us know. We'll look forward to seeing what that patient care guideline looks like. And then sounds like we all get an opportunity to talk about it some more, which will be good. I think it's really important. So folks know there will be a 2025 protocol update video that'll be released sometime later this month. We also are continuing to work towards training documents for small training for the missed drop-off process as well. So hopefully both of those will be completed before the end of the month. Are there any other items from the floor? Alex, anything from the state?
No, we're just out doing our normal inspections. Only question I have, you mentioned the protocol update. Where's that going to be published?
That'll be published on the Remo YouTube channel, as it's been published every year. So Alex reminded everybody as they're out doing their inspections, he does not promise to be as collaborative as the DNV, but I'm sure he will be. So that's something to look forward to. So forward to those inspections, and realize that those inspections are just making sure that we have the tools to do our job. And so our patients are getting the care that they really deserve and that you want to provide them. So that's good. Beth, Don, nobody else in the room? Okay, anybody online? Anything further? All right, well, if I can have a motion to adjourn. Several in the room. All right. Thank you all. Oh, yes, Steve. Oh, sorry, Anand. Sorry.
Just one note that I threw in the chat there about the mixing of the NOR-EPI in a 1,000 bag versus a 250 bag. I know we had a short discussion about that a while ago about keeping the concentrations the same, and that's why the committee wanted to keep that in a 250 bag. However, my argument of keeping the concentration low while also administering volume to those patients is also important, which is why I argued for the administration in a 1,000 bag, making that a little easier as well to calculate middle of the night, doing something like that. Is that something that others are considering? Is that something that the MAC should be addressing at this point, or?
And I think the other thing that comes in with that is when we originally switched to 250 of D10, the goal was that the only 250 that we would carry would be the D10.
Right.
This was discussed pretty exhaustively at the with the collaborative group, but I think bringing it back out with your thoughts makes a ton of sense. Let's make sure that that's on the agenda for the next protocol committee meeting, so we can talk that through. So I think it's
Fantastic.
important. You make good points. Very good points.
Anon, this is Beth. Would you get a hold of me and we will submit it under the red cap? So we get a good description of what we're trying to communicate into the collaborative protocol committee.
Absolutely, I'll do that.
Thank you.
Thank you, Anand.
Thanks, Doc.
Mike, is next
Yes, sir.
meeting May or June?
Next meeting is June. I
Thank
believe
you.
it is June 4th. Who has it in front of them?
I can find it. I
I
just,
have June 4th.
June 4th. Thank you, John.
thank you.
Thank you, Sam. Thank you, Beth. Excellent. All right. With hearing nothing else, thank you all, and I will see you all on June 4th, if not before. Thank you.